All right, so this quality measure that we're going to talk about in regards to coding MDSs is dealing with the percentage of residents experiencing one or more falls with major injury. So the rationale for the measure is that falls are considered the leading cause of injury, morbidity, and mortality in older adults. Previous falls, especially recent, recurrent, and falls with significant injury, are critical predictors of risks for future falls and falls that will eventually become injurious. So if you've been having people who fall and fall and fall and they're not getting hurt, that's like rolling the dice. It's Russian roulette with the falls. So you want to make sure that you're taking a look at that and you're paying attention to it seriously. Residents with a history of falls might limit their own activity due to being afraid of falling, and then you can have significant impact on their quality of life. You can have increased depression. You can have changes in ADLs just simply because they're not moving around as much because they're fearful. And then residents with history of falls really need to be evaluated for any reversible causes. So the REI manual defines a fall as an unintentional change in position coming to rest on the ground, floor, or next lower surface. So they could be rolling off onto a lower mattress, onto a second bed that was there, onto the chair. They could stand up and fall back. If they're in one of those Mary walkers, standing up and then falling onto that strap that comes up between is an unintentional change in position to a lower surface. All right, the fall may be witnessed, it could be reported by the resident or an observer, or it can just simply be that when the resident is found on the floor or the ground. All of those things would be considered falls. They include any fall no matter where they occurred. So it could be at home, it could be out in the community, it could be in the hospital or in the nursing home. The only time you're not going to code something as a fall is when it's the result of overwhelming external force. So another resident comes by and pushes somebody and they fall down. The person who fell is not going to be marked as a fall, okay? We also need to make sure that we know that an intercepted fall is still considered a fall. And that occurs when the resident would have fallen if she hadn't caught themselves or if someone hadn't interceded and stopped the person from falling. Lowering to floors is still an intercepted fall. So you want to make sure that you're paying attention to the kinds of conversations your staff are having. Oh, she almost fell, but you got to consider those things falls. You got to take a look at that, and you want to investigate what happened and what you can do to keep that patient safe. And as with all quality measures, the data is coming for any of the MDS driven from the actual MDS answers. So how are they coded on the MDS? Well, falls are all in section J. You have J1700, which is looking for a fall history, J1800, that's talking about the falls since they've been with you, their admission, their entry or re-entry, or since a prior assessment, and J19, the number of falls since they've been with you, the admission, the entry, the re-entry, or prior assessment. So when we're looking at the number of falls at J1900, these are falls that are only on OBRA or scheduled PPS assessments. All right, so the look back period is going to be the first day after the ARD of a last scheduled assessment. So if you have COTS and starts of therapies and end of therapies and other things that are in between those scheduled assessments, those don't count. You have to make sure you're going all the way back to the first day after the last scheduled assessment and then through the ARD of a current scheduled assessment. All right, and so when we're looking at numbers of falls, again, we're talking about from their most recent admission or entry or re-entry or the prior OBRA or PPS scheduled assessment, whichever is more recent. We would code falls as either being 0 for none, 1 having 1 fall, or 2 as 2 or more. You're going to put those numbers whether they have no injury, an injury that's not major, or a major injury. So if they had 23 falls without injury, you would put a 2 in the no injury. Okay, 1 fall with a skin tear or a sprain, you would put a 1 in the injury box. And 1 fall that had a major injury, they fractured something, you'd put a 1 in the major injury box. So you're going to put the number of falls here. The most it can be is 2, but that is going to represent anywhere from 2 to 62. So 1900, no injury. That means the resident has had no evidence of injury on a physical assessment by the nurse or the doctor, no complaints of pain or injury by the resident, and no change in their behavior after the fall. So it's important that you're looking at those things in addition to just doing the vital signs 3 days post-incident. All right, because if a resident starts complaining of pain and you don't link that back to the fall, you could be missing a problem there. All right, so again, either no falls without injury, one fall with no injury, or 2 or more falls with no injury. 1900B, injury that's not considered major. All right, this will include your skin tears, abrasions, lacerations, superficial bruises, hematomas, sprains, any fall-related injury that causes the resident to complain of pain. Again, looking at making sure that you don't just check vital signs for 3 days, but that you're looking at pain for this person to make sure that that pain that eventually develops isn't or can't be linked back to a fall that they sustained. Coding 0 for no falls with injuries, 1 for 1 fall with injury, 2 for 2 or more falls with injuries. And J1900C is where we are capturing the major injuries. So these are bone fractures, joint dislocations, closed head injuries that with changed consciousness, subdural hematomas. And you want to make sure that if you discharge a patient to the hospital because of a fall, and you don't have a diagnosis of one of these things that indicates it's major injury, you're not off the hook, all right? Just because the ARD ended with the day of discharge and 2 days later or 1 day later we get the diagnosis or the patient comes back to us 4 days later with that fractured hip or subdural hematoma on their diagnosis sheet, we have to go back and modify that discharge assessment if we've already completed and sent it to include that validated diagnosis. You need to make sure you do that. I'm not certain that everyone had been doing that in the past. It's like, oh, it didn't show up on the discharge, so we don't need to do it because we didn't have that diagnosis yet. Right? There's a clarification by CMS that this has to happen. So transmission warning, we want to make sure that we are not transmitting managed care assessments that are just used for payment. Okay, for these sources, an admission assessment, you would use that for their 5-day. You would not code it as an admission 5-day. So it would only be an admission and it would go, and then you only transmit any assessments that are OBRA required. And the DON and the administrator really should consider reviewing all the MDSs coded for falls with major injury prior to transmitting them. Once it goes, if it's wrong, you can go back and modify it, but the data is still going to be calculated in your quality measures. Right, wrong, or indifferent, that's the way they've decided to do it. And so when they use all assessments, that means even modified assessments, wrong assessments, it doesn't make a difference. You need to make sure this information is accurate before it goes, because after it goes, it's too late. So how do we improve this measure? Prevention, prevention, and more prevention. We want to have thorough assessment and reassessment. We want to have adequate, timely, and consistent interventions. And then we need to create a facility-wide fall prevention culture. So thorough assessment and reassessment, we got to make sure we're following our policies and using any of our quality assurance performance improvement tools. We want to assess people upon not only admission, but their readmissions for things that might have changed since they were in the hospital. And we want to investigate and gather the necessary information. When you have people that are falling and you can't figure out why, and you've used all of your little bag of tricks, and we really get comfortable with the same set of interventions. You can go and look at people's fall care plans, and you're going to see the same 3 and 4 interventions. And eventually you start getting to a point that you think, well, what else can I do for this person? They're going to fall. They're going to fall. And that may be true. And your job then is to make sure that when they do fall, they're not going to be getting hurt. But a suggestion would be that when you have your weekly risk meeting, that you take the most recently completed CAW from the system for falls, and this works for other quality measures as well, and have that printed out and start using that week after week as a tool to help you look for different interventions, to look for different risks and potential to keep this person safe. They've done a really nice job with the MDS 3.0 and the CAS and CAT worksheets, but we don't use that data for anything more than paper compliance. So we really need to get into the habit when you can't figure out why somebody keeps losing weight, why somebody's wound won't heal, why they keep falling, why their medications aren't helping them with moods and behaviors. Pull those CAS to those risk meetings, keep them in a binder, and week after week add notes to them, and then you have this ongoing record of what you've tried to do that you can use in the medical record. So this is what a CAT worksheet would look like for falls, and you can see that it talks about the history of falling, so you can take a look at some things that were going on with the person, their physical performance and limitations related to gait and balance and strength. There's talking about orthopedic concerns, missing limbs, fractures, perceptual, they have some dizziness. You might want to look at, do they have some sort of infection going on, pain, fatigue, weakness, vitamin D. So you don't have to hit them with everything, but opening up this CA and using this CA might say, okay, well, that didn't work. They're still falling. Let's check for this. Let's run this. Let's do this. What about this? Do they have glare? Do they have a patterned carpet? How are their shoes? You know, what's their proximity to aggressive residents? It gives you lots of different things to consider so that we don't get into the rut of using the same 3 and 4, and particularly when the new changes come in October, where we're going to start addressing alarms that we use on the MDS. All right, alarms do not prevent falls. So again, how are we going to improve this measure? Through the use of adequate, timely, and consistent interventions. Okay, we can't have somebody fall and then wait until we get to the risk meeting a week later to figure out if we have an appropriate intervention in place. They need to be talked about in morning reports the next day and making sure that interventions were there and that the resources are available for nurses to do what they need to do on the spot. Proactive intervention. Get the resident involved in activities and exercises that build their core strength and confidence. All right, look for the different types of exercise programs, restorative programs, all of those types of things that we can get them up and moving about. And then we have to develop a culture of awareness that each time staff members go into someone's room, they're looking for or asking questions about things. So this has been referred to in the industry as 5 Ps: position, personal needs, pain, placement, and presence. Okay, some people will even put up little things, by somebody's bed. That's a picture that identifies to somebody that this is a fall person and we're looking for these 5 Ps, or they'll just put a 5 or something that doesn't indicate to anybody outside of us what that means. Is the resident comfortably positioned? Are they falling asleep in a wheelchair? All right, if they're falling asleep in a wheelchair, you may want to get them out of the chair and put them in bed. Personal needs. Does the resident need to use the bathroom? Do they need to have their briefs changed? Pain. Do they seem to have some pain, be uncomfortable? Placement. Are personal items within reach? Their call bell, or is it still wrapped around a side rail on the other side of the bed? Tissues, remote controls. And just presence, people being able to check on the above items frequently. So even in between call bells ringing, people should be up, walking up and down halls and not necessarily sitting at the nurse's station outside of doing their documentation. Improving quality measures really is a matter of improving our scope of observation, getting the whole team involved to capture the whole picture, improving communication, sharing what we see, hear, know, and learn from all disciplines, rededicating our commitment to the residents' well-being, and ultimately just maximizing the quality of care available to the people we serve. So you can count me in for all of that. I'm going to tell you a true story about people that have fall risk meetings, and you might have 6 or 7 people around a table in a room, and we had this patient who kept falling, and she was always falling around change of shifts. So right away you're thinking, well, that's because they're distracted with report, or people are coming and going and no one's paying attention, and all these types of things. So we kept having these meetings in the room, in the conference room, and we decided to go and find out at her bedside, what's the problem? Why is this lady falling out of bed at these particular times? We're thinking she's incontinent, we're toileting her, it doesn't work. So we go there and we see that the fire doors had been closed by the nurse's station, and her room was just on the other side of those fire doors. So they are doing the report, and I asked why the fire doors are closed, and they said, well, because we had a grievance, and the resident said that it was too loud during shift change, so we now close the doors so they don't hear everything that's going on. All good and well, valid response to a grievance. However, every time people walked through those fire doors, the door kept squeaking and it sounded like a cat meowing. And when you looked at the investigation reports for the resident, she kept saying, I got to feed the cats. I've got to feed the cats. And everybody's thinking she's dementia. There's no cat, there's nothing to do with their falls. Indeed, it did have something to do with her falls. We put WD-40 on the hinges of those fire doors. The squeak was gone, and so were the falls. And that's a true story. You've got to look outside the box. We got to move these meetings. We got to make them mobile in the environment where we're seeing things happen. That's the only way you're going to change these outcomes.